Hi all, I am Dr. Anitha, Assistant Professor in the Department of Periodontology, Vinayaga Missions, Sankaracharya Dental College. Let's move on to today's topic. So today's topic, it is on prognosis. So these are all the contents we are going to deal in detail. So it is the introduction, definition, what is the need for prognosis, classification, determination of prognosis, relationship between the prognosis and the diagnosis, re-evaluation of prognosis after your phase 1 therapy, conclusion and your references. So moving on to the introduction. So periodontal prognosis is an integral part of periodontal practice and it influences the treatment planning as well. So this word prognosis is derived from the Latin word foreknowledge. So according to Niels Bohr, what he has said, predictions are difficult, especially about the future, isn't it? So actually this prognosis is actually made before the treatment planning but after your clinical diagnosis. So prognosis, according to Goodman et al., so the prognosis, it is a prediction of the probable course, duration and outcome of the disease based on a general knowledge of the pathogenesis of a disease and the presence of risk factors for the disease. Moving on to the next slide. So what do you think for the need of prognosis? So the need of prognosis, it is that it is an integral part of periodontal practice as it directly influences your treatment planning. So this determination, support and guides the clinical decision making. So it also underlines the economic importance, isn't it? Then how it is made before the treatment plan is established? Based on the specific information about the disease and the previous experiences. So you need not confuse with the risk. So the risk is nothing but the likelihood that an individual will get the disease in a specified period. So let us move on to the concepts in prognosis. There are three important concepts. The first one, it is your definition of the intended outcome. Second is timing of projection. Third is consideration of overall prognosis versus your individual tooth prognosis. So first important concept, it is your intended outcome. So there are various types of outcomes, that is your true outcome and your surrogate outcome. So in periodontology, in our specialty, this true outcome, that is nothing but whether to retain your tooth or not. Then what do you mean by the surrogate outcome? It is your attachment loss. Right? Moving on to the second important concept, that is your timing of projection. So the periodontal prognostication is an evolving and a dynamic process. So hence it should be evaluated periodically as treatment and the maintenance process. Second concept, it is your timing of projection. So periodontal prognostication is an evolving and dynamic process. So hence it should be evaluated periodically as a treatment and the maintenance progress. So the maintenance progress, it can be a short term or it can be a long term. If it is a short term, it should be within the 5 years. If it is a long term, it should be more than 5 years. So third important concept, it is your overall prognosis versus individual prognosis. So overall prognosis, what are all the factors that determine the overall prognosis is that the factors that may influence the is number one, patient's age, the current severity of the disease, systemic factors like diabetes and all, smoking, presence of plaque and calculus and the patient compliances. So what will be the individual tooth prognosis? That it will be determined after the overall prognosis is determined and it is affected by it. So we have been commonly taught clinical factors which is used in assigning the prognosis. So we have seen the overall prognosis factors. Let us see what the individual tooth prognosis determine. So it is determined according to the percentage of bone loss, deepest probing depth, or the bone loss whether it is a horizontal or vertical, the furcation involvement, that is your grade 3 furcation or grade 2 furcation, mobility whether it is a grade 3 or grade 2, whether favorable or unfavorable crown root ratio, favorable or unfavorable root forms, tooth malpositioning, fixed or removable abatement. So these all determines the individual tooth prognosis, and we have already seen the overall prognosis, all these factors before itself. So this has been classified, this prognosis has been classified, and it has various classification systems according to different scientists. So mainly it is based on the similar clinical and radiographic findings, and also the parameters which is related to maintenance procedures, right. So according to the Hirschfeld and Wasserman in 1978, they have given us the favorable and questionable prognosis. Whereas Becker et al. In 1984, they have given us a questionable and hopeless prognosis. Whereas the accepted classification is that, and what we are following is that McQuarrie and Nunn classification system. They have categorized the prognosis as good, fair, poor, questionable, hopeless. So according to them, if the control of etiological factors and enough clinical radiographical periodontal support is enable the tooth to be maintained by the patient and the clinician with the proper maintenance, it falls under good prognosis. Okay. If approximately 25% of your attachment is lost and the class 1 furcation involvement is there, but it allows the adequate maintenance, then it falls into fair prognosis. The same attachment loss, it has exceeded the 25%, that is it is around 50%, and the class 2 furcation is there, but it is can be maintained with some difficulty, it falls into poor prognosis. And if the attachment loss is more than 50% with the class 2 furcation, class 3 furcation as well as class 2 mobility and significant root proximity, all this falls under your questionable prognosis. So if severe attachment loss, extraction should be performed or suggested, these are all falling under the category hopeless. Okay. So are you all clear with these types? This is more important, and this will be followed in your case sheet taking. Next classification is that Quark and Caton classification. They have categorized prognosis into 4 types, that is favorable prognosis, questionable, unfavorable and hopeless. So what factors that determine the prognosis? So the factors which falls into all these 4 categories, like overall clinical factors, that is your patient's age, disease severity, plaque control and patient compliances, how well the patient responds to your treatment. So second one, it is a systemic or environmental factors, that is your smoking, systemic diseases like diabetes, genetic factors, stress, all this falls into this systemic or environmental factors. Local factors, you all know that plaque and calculus, it falls under your local factors. Apart from that, anatomic factors like your cervical enamel projections, enamel pearls, bifurcations, trifurcations and root concavities, tooth mobility, all this falls under your local factors. So prosthetic and your restorative factors, that comprises of abutment selection, caries, non-vital tooth and your root resorption. So moving on to the first factor, that is your patient's age. If you take 2 patients of different age category, the patient who is older, they have a good connective tissue attachment and the alveolar bone prognosis, because the younger patient, they have a shorter time and more periodontal destruction. So comparatively, the older patient, they have more connective tissue attachment and the alveolar bone prognosis is better when compared to your younger patients. So the periodontal destruction observed in the elderly is one of the lifetime disease accumulation and not an age of specific condition, which was given by AAP in 1995. So moving on to the second factor, that is your current disease severity, that is your pocket depth. You should elicit the pocket depth, the level of attachment, degree of bone loss and the type of bone defect, whether it is horizontal defect or it is a vertical defect. So in this case, you have 2 pictures which shows a vertical bone loss. So in this bone loss, the initial level, bone level, it is a greater prognosticator than the residual bone level. So the deeper the intra-bony defect, the greater the potential of bone degeneration and more favorable the prognosis. Moving on to the second slide. Same way, the prognosis for the horizontal bone loss depends on the height of the existing bone. For example, you see the height of the existing bone, it is near the middle third of the tooth root. So the angular defects, if the contour of the existing bone and the number of the osseous walls, they are come into the favorable prognosis category. So in this picture, if you see When a greater bone loss has occurred on one surface of the tooth, the bone height on the less involved surface should be taken into consideration while determining the prognosis. Compare this A picture with this B1. So moving on to the third factor, that is your plaque control. This bacterial plaque, which is primary etiological factor for all the periodontal destructions and periodontal diseases, should be effectively removed by the patient on the daily basis. So coming to the patient compliances, that is nothing but your patient cooperation. Imagine that if you are treating a patient and he refuses to accept the treatment, or even after the surgical procedures or even after the treatment procedures, patient is not following the oral hygiene instructions whatever you have given, whether that treatment will be successful? No, never. So the patient compliances plays an important role in prognosis. So if the patient refuses to accept the treatment, or if the particular teeth is hopeless and it has to go for extraction and it has to be extracted, then we can perform scaling and root planing on the remaining teeth. So moving on to the environmental factors, that is your smoking. The patient should be informed about the smoking effects. It not only affects severity of periodontal destruction but also the healing potential of the healthy periodontal tissues. So it has a direct relationship, that is the smoking and the prevalence of incidence of periodontitis. So it affects the severity, it affects the healing, and if there is a slight to moderate periodontitis, the prognosis will be fair to poor. If it is severe periodontitis, then the prognosis will be poor to hopeless. So if you know all these only, you can educate a smoking patient. So moving on to the systemic diseases and conditions. For example, you all know better, like type 1 diabetes and type 2 diabetes are there. The prognosis will be dependent on again the patient compliances, which is related to both medical and dental status. If it is the patient is in a well controlled manner, then the disease severity will be slight to moderate periodontitis, and the prognosis also it will be very good. And then moving on to the genetic factors, you all know the genetic polymorphism in interleukin 1 genes, which results in the overproduction of interleukin 1 associated with the insignificant increase in the risk of severe chronic periodontitis. So all this leads to a periodontitis problem. Whereas in aggressive periodontitis, the genetic factors which influences the serum immunoglobulin G2, it titers, and the expression of these receptors on the neutrophil will result in aggressive periodontitis. So it is very necessary to identify the genetic factors which can lead to the treatment alterations, like you can give them the adjunctive antibiotic therapy and frequent maintenance visit. With this, the periodontitis will be in a controlled manner. And moving on to the local factors, as I have already told you, the bacterial plaque and calculus, which is a most important local factor in all the periodontal diseases. So if you want a good prognosis, it totally dependent on the ability of the patient and clinician to remove the etiological factor. Subgingival restorations. If you see a patient with the subgingival restorations, you have to educate the patient that it may contribute to increased plaque accumulation, increased inflammation, increased bone loss, and the subgingival margins, which will result in poor prognosis. So which should be treated at the earliest. So moving on to the anatomic factors like short tapered roots with larger crowns, cervical enamel projections, enamel pearls, intermediate bifurcation ridges, root concavities, and developmental growths, all these predispose the periodontium, normal periodontium, to diseased condition. So teeth with the short tapered roots and relatively larger crowns, they have a poor prognosis. Before treating that particular teeth, you have to have all these in your mind. So in this picture you can see the CEPs, then the developmental enamel grooves, which is the plaque retentive area, which is difficult to instrument as well. So the prognosis for this kind of individual tooth, it is very difficult. So prognosis obviously it will be poor. And root concavities exposed through the loss of attachment can vary from shallow flutings to deep depressions. So they appear more marked on the maxillary first premolars and the mesiobuccal root of the maxillary first molar, this part. So although these concavities increase the attachment area and produce a root shape that may be more resistant to torquing forces, but they are inaccessible to clean, which results in a poor prognosis. So moving on to the tooth mobility, what will be the principal causes of tooth mobility? That is, number 1, it is your loss of alveolar bone, then inflammatory changes in the periodontal ligament, third, it is your trauma from occlusion. Fourth, the stabilization by use of splinting, which is beneficial impact on the overall as well as your individual to prognosis. So there is a general saying by the Harlan and Nunn. They have concluded that there is an evidence that untreated occlusal trauma is certainly a catalyst which boosts for the progression of periodontal diseases. So as soon as you elicit or as soon as you detect this occlusal trauma, you have to treat that first and then the other complaints the later, because if the occlusal trauma, if it is left untreated, it eventually causes the tooth mobility, bone loss, mobility, and then the tooth will be extracted if left untreated. Then comes your prosthetic or restorative factors. So if you have many teeth and the overall prognosis should be taken into account, that is, it requires a general consideration of bone levels, attachment levels to establish whether the enough teeth can be saved either to provide a functional and the aesthetic dentition or to serve as an abutments for useful prosthetic replacement of a missing teeth. If you have fewer teeth, imagine only 30% of the teeth is remaining in a patient. So in that particular condition, the prosthodontic needs become more important, and sometimes periodontally treatable teeth may have to be extracted if not compatible with the design of prosthesis. So perpetual preservation of what remains is more important than the meticulous replacement of what has been lost. So finally we are moving into the last factor, that is your caries, non-vital and root resorption. So imagine a teeth which has been severely mutilated by extensive caries. The feasibility of adequate restoration and the endodontic therapy should be considered before undertaking the periodontal treatment. Extensive idiopathic root resorption or root resorption that has resulted due to the orthodontic treatment, which risks the stability of the teeth and adversely affects the response to the periodontal treatment. So moving on to the relationship between the diagnosis and prognosis, when comparing the factors such as patient's age, severity of the disease, genetic susceptibility, presence of systemic disease, they are all important in developing both the diagnosis as well as the prognosis. So all these factors, they are all common for both diagnosis as well as your prognosis. So prognosis for patients with gingival diseases, this has been categorized into two, that is dental plug induced gingival disease and non-plug induced gingival disease. So the plug induced gingival disease, there are four important factors which fall into this category, that is the gingivitis associated with the dental plug only, plug induced gingival disease modified by systemic factors, plug induced gingival disease modified by medications, gingival disease modified by malocclusion. So what will be the non-plug induced gingival lesions? It is seen in patients with a variety of bacterial, fungal and viral infections. So some dermatological disorders such as lichen planus, pemphigoid, pemphigus vulgaris, erythema multiforme, lupus erythematosus, all this manifest in the oral cavity as a atypical gingivitis. So some others like allergic, toxic, foreign body reactions such as all hypersensitivity reactions as well as mechanical and thermal trauma can result in a gingival lesions. So what will be the prognosis of patients with chronic periodontitis? So in chronic periodontitis, in cases where the clinical attachment loss and the bone loss are not very advanced, the prognosis will be good. If the inflammation is controlled through good oral hygiene and the removal of the local plug retentive factors, which will eventually result in good prognosis. Whereas in aggressive periodontitis, definitely the prognosis is very poor, because in localized aggressive periodontitis, which is occurring around your puberty, it is localized to your first molars and the incisors, the patient exhibits a strong serum antibody response to the infecting agent, contributing to the localization of the lesions. So if it is diagnosed early, then it can be treated conservatively. If it is in advanced stage, then the prognosis can be good if the lesions can be treated with the debridement, local and systemic factors, elimination using the antibiotic therapies and regenerative therapy. So what happens if the periodontitis as a manifestation of systemic diseases? So it is divided into two categories, that is periodontitis associated with the hematological disorders and the periodontitis associated with the genetic disorders. The systemic diseases that affect the progression of the disease, and thus the prognosis is fair to poor in both the categories. So for example, if you take hypophosphatasia, there will be a severe alveolar bone loss, premature loss of deciduous permanent teeth and connective tissue attachment loss. So here the prognosis will be fair to poor. Taking NUG and NUP, that is your necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis. So in NUG, the primary predisposing factor, it is your bacterial plaque. So the prognosis for the patient is very good if the local factors has been removed, and with the repeated episodes of NUG, the prognosis may be downgraded to the fair prognosis. So if the disease which is complicated by presence of secondary factors such as acute psychological stress, tobacco smoking, poor nutrition, these all leads to immunosuppression, and hence the prognosis will be poor. So with control of both bacterial plaque and secondary factors, the prognosis will be good, although the tissue destruction is not reversible. But whereas in NUP, which is similar to the NUG, that is your necrotizing ulcerative periodontitis, which is similar to the necrotizing ulcerative gingivitis, except the necrosis that extends from gingiva into the periodontal ligament as well as your alveolar bone. So many patients who are all presenting the NUP, they are immunocompromised through the systemic conditions such as HIV infections. Moving on to the re-evaluation of prognosis after phase 1 therapy, this is the most important step which final year students, you don't perform this after your treatment plan. So you have to keep in mind that after the phase 1 therapy, that is scaling and root planning, when concerned to our department perio, you have to recall the patient after 14 days for re-evaluation. Okay. So what you will be re-evaluating, whether there will be a reduction in pocket depth, inflammation, all this indicates a favorable response to treatment and may suggest a better prognosis than previously assumed. So if the inflammatory changes are not controlled or not reduced after this phase 1 therapy, overall prognosis is unfavorable. In these patients, the prognosis can be directly related to the severity of the inflammation. So to conclude my presentation, you have to keep in mind that prognosis helps in planning the customized treatment for each patient, thus helps in providing overall care to the patient. So it should be given due importance in general clinical practice. So what is that? Prognosis should be made before the treatment planning but after your clinical diagnosis. So future studies should focus on development of simplified prognostic models with high predictability, which in turn will increase the confidence of both the dentist and the periodontist when assigning the prognosis. So these are all my references. Thank you for the patient listening.